the individuals in this community. There is truly a passion and a commitment to be sure that you get the care you deserve, where you live, as much as is reasonably possible. We have over 120 volunteers that serve in different capacities in different boards as a part of our organization, including our foundations, our affiliate boards, and the parent board. It truly is a committed group of individuals who have given up their time, their heart, their soul, to be sure that you continue to receive the care you deserve. I would like at this point, if you'll bear with me, current leadership, Kevin Ryan is our chair, Cynthia Lowe, our vice chair and immediate past chair. I'm not sure if Craig Sickler here. Steve, you can stand in for me. Craig is our treasurer, and Nancy Davenport is our secretary. And it'll take 2 seconds. Could those that had served in any capacity on any of our boards or committees please stand up? Just to remind you, there have been some words out in the community that Health Alliance is a healthcare conglomerate that owns several hospitals throughout the Northeast states. I can assure you that Health Alliance is local. Thank God. Starting in 06, 07, 08, there's also been some word in the community that this was thrown together at the last minute by a group of people that came in from the outside. And I can assure you that did not happen. But the board took the challenge and ran with it. Those 3 years involved meticulous planning of many conversations internally, as well as bringing in outside consultants that have experience in this type of thing, working with the Department of Health, arm in arm, the Burger Commission, the Archdiocese, and others that we've covered in previous presentations here. It was not an accident. It was meticulously planned to be sure that this community receives the care going forward. There were public forums, and the consolidation was based on the commitment to make it work. When I arrived, the master plan was in place. Brilliant document and structure to be sure that it was strong enough to make the changes, but flexible enough to make it happen. And our board, our community has been in lockstep with us through this entire process and will always be. It's the nature of the community. So, as a part of that, and I'll close on the history part, just on that, because of the efforts, the DOH viewed us as the poster child of the Burger Commission because it was a true life example of the community coming together, solving a problem at that time and making it work. Preserved a secular hospital and a Catholic hospital working side by side under a parent organization that was truly important to the community at that time, because the mandate was work together or close one. If that would have happened, over 700 jobs would have been lost. So, let's launch. First year, March of 2009. $15 million in efficiencies and additional rate increases allowed us to generate an operating gain. In the world of healthcare and the changes that have begun, triggered, I believe, by and accelerated by the economic collapse, changes in reimbursement, we began to see some deterioration in 10, as you can see. Also, the evolution of healthcare in outpatient services moving out of the hospital that had historically been a part of it, now going into physician offices and other facilities with the purpose of reducing the overall cost. It was payer driven, and we began to see that dilution in 10. In 11, we saw a full year of it. And it was very clear that the model we had was not sustainable going forward. Therefore, it was time to face what will occur and how do we adjust as much ahead of it as we possibly could. Led to the decision, and please forgive the simplicity of this. This in no way can begin to picture the difficulty that we have been through this past year. Think about it. The realization that we could not maintain 2 hospitals. We had leaned out operations to where every service generated a margin. But we could not, because we had to maintain 2 full facilities, sustain financial viability. It was gut-wrenching and tough. But getting back to the commitment of what this organization was put together to do, it was necessary that these tough decisions be made. The courage, the insight, the drive, and the commitment were extraordinary. So, if we look at, and forgive, I'm going to go from the bottom up. In May of 12, it was clear that we needed to move to a single campus. That launched the address of a year ago, in which I met with this esteemed group and shared the fact that this was necessary going forward. Since that time, for the last 6 months of 2012, extremely intense, and we had community forums. We met with the Department of Health on multiple occasions and spent many hours developing a variety of different models. We looked at every possible iteration, looking at either of the 2 hospitals to be sure that we were confident that the final decision would be our best, given the conditions. So, getting to that point, and think again of the emotions that have been experienced. You're taking a Catholic hospital and making it secular. And we're moving out of the facility of the other hospital and combining into one. It's no wonder the emotions, the fear, the question, the confusion exists. But I can assure you, our commitment is to be sure you get that care that you deserve. So, in early February, we did get an approval, a preliminary approval by the Department of Health of a plan that will preserve most of the services we currently provide. We needed to gain access to the Marys Avenue campus. Extraordinarily difficult, emotional, as you can imagine. We worked side by side with the sisters to be sure that we did it right. And the end result is, as a mandate from the state, if you have a single hospital in a community, it must be secular, full service. And we met that. We've also engaged a design-build firm to make the changes to the facility at Marys Avenue that will accommodate all the services, essentially all the services. We're now in the midst of putting our financial plan together to put the pieces together to launch the plan. This plan will allow us to go from an operating loss to an operating gain. And it's, again, critical that we move forward. So, Let's talk about some of the progress that has been made. Now, what this says is we stabilize the market during this period of confusion. That's all it says. We need to be at 70% of our market share, not 61%. To be a true community hospital, meeting the needs of our community, we've got some work to do. And that's our commitment, to be sure that we fill the gap and you get the services you deserve. Now, let's talk about access to quality care. During this period of time, we've received numerous accreditations for safety and quality. We've seen growing, profitable service lines in orthopedics, cardiac care, and vascular surgery. The awards, just to pick a few, top 5% in the nation, patient safety, health grades, certified chest pain center, the only in the Hudson Valley, speaks to the quality of our cardiologists, certified stroke center, again speaking to the strength of our neurologists, and obviously our nurses and our caregivers. We were the first Joint Commission certified Center for Breast Health in the state. Gold seal of approval. The core quality measures are just indicators of clinical quality. The number is now up to 40. As of at the close of 2012, we were at or very near 100% compliance with each of those. Again, that doesn't happen by accident. It happens with the coordinated effort of our physicians, our nurses, and our caregivers. We have an exceptionally strong medical staff for a community hospital. Full spectrum of specialties, including a very strong group of primary care physicians. Our community is blessed with excellent family physicians, internists, and specialists. This past year, 13 of our physicians were recognized in the top 101 docs in the Hudson Valley. Again, very well trained in the best schools, choose to live in this community because of the community and its surroundings. Included in this is a long-term relationship with the Institute for Family Health that has been the source of many of our great physicians. We enjoy a great relationship with them in the training of new physicians. And as I said, many of which have stayed in the market and provide the excellent care to you and to this community in the care of our families. This is critical going forward, because now we're going to spend a bit talking about what that future looks like. Now, one thing too that's important. Who do we serve? 1/3 of our patients reside in Kingston. And as many of you know, it has a lower income and higher poverty levels than the state or the county. So we get back to access. It's our responsibility to treat anyone with the best of care, regardless of their economic condition. We stand true to that, and that truly is our commitment. And I can honestly say there have been some criticisms of we only focus on money and not care. I'm hoping that you begin to understand that is not at all the case. If we're going to be successful, we have to be the best at what we do in the quality of care. And there is no confusion about that. So we're moving forward with that understanding. Population growth, the realities going forward. We're going to see total population stay flat. But within that population, we're going to see a double-digit increase in those reaching Medicare age, and a decline in the younger, the pediatric population. We're not totally unusual with communities throughout the country, but it is something that we need to understand and know, that our population is aging in place, and we need to be prepared for that. Now, a little bit on the background of national and state health care trends. This is now where it hits reality. The Affordable Care Act, board that you referred to, has $21 billion in cuts scheduled over the next 10 years. We've seen $17 billion in cuts the last 10 years, $5 billion in Medicaid over the last 3 years. And the sequestering, I don't know that anybody fully understands the results of that because it's a work in progress, but it will affect us. And as we look at the projections for all of healthcare, for us, the early numbers are in the tens of millions over the next 10 years. So it's important that we understand that and adjust accordingly. Now, for those of you who've been around, you know of our issue with the MSA and the fact that our wage index was artificially removed from an adjustment made back in 2003. That's a $10 million adjustment to this community. And you put that over a 10-year period. Doesn't take a calculator to determine the amount of money that is available to our surrounding counties and to those that are only 5 miles away. $10 million a year. It has been addressed many times, many ways, and I can assure you we are putting our foot on the accelerator with that. It's wrong. It must be fixed. No guarantees, as we know, over the last 10 years. So, what are the forces changing our business? Cost will outpace revenue for the reasons that we talked about. So, what do we focus on? Highest quality. We do have market share to grow, and if we're the best at what we do, we will see that grow. Efficiency. We must do it at the lowest possible cost. And productivity. We must set up our systems to support our staff so it is the most efficient environment so they can provide the care in the best manner possible. The patient mix shift. Medicine, less surgery. The evolution of healthcare is not something you can argue with, because what we want to do is become more active in the world of wellness and health. The idea is to increase the health of a community to prevent hospitalizations. Strange that hospitals would be in the midst of an initiative to discourage hospitalizations. Now, not discourage when it's needed, because there will always be a need for hospitals. But what we will see is those in hospitals will be very sick or will require interventional services that cannot be provided elsewhere. So our role in the community will change. And driving that is our ability to work even closer with our physicians and services within the community. We're going to see our population, as we talked earlier, live longer with more complex conditions. We're going to see, again, more and more procedures being located in outside hospital facilities for purposes of cost and convenience. Insurance mix shift. More Medicaid, Medicare, the Accountable Care Act, the Affordable Care Act. That's interesting. We'll expand insurance coverage, as you know, or probably heard in your businesses. New York State has taken a lead in launching the health insurance exchanges. The launch date is October. It's still a work in progress. The actual end result has not yet been determined. Again, our aging population will increase our Medicare enrollment. Okay, I've described the environment and the challenges. Now, what are we going to do about it? Physician alignment and consolidation. It's always been the right thing to do, to work arm in arm with our physicians, but it's taking on a much higher sense of urgency now. To accomplish what is given for us in the future, we must work exceptionally close with our physicians. Physician integration. You're going to hear in my finishing remarks much to do with integration and partnership. We're all in this together. Physicians are facing rising expenses as we are in the hospital business, and they need and want a stable environment. So you're going to see, and you've probably heard, increased consolidation and the formation of large multi-specialty physician practices. It is inherent in our existence to align with them, work with them, blur the lines so that we are active partners. Our role for the future, no question. Quality and performance improvement. We need to limit hospital stays, readmissions, hospital-acquired infections. These are all good. We need to be doing this. Earning the right to be considered your leading hospital provider. It's not something that can be cheaply accomplished. We must earn it. We know that. Being a good partner to not only other healthcare providers, but to our community. Providing convenient and accessible services, and unique to us, protecting and preserving 100 years of two hospital legacies, combining it and using that as a point of strength, not as a point of adversity. Both hospitals have provided excellent care over the years, and it is our commitment to be sure that those legacies are not forgotten, but that they are built on. Wellness partner. How do we do this? You're going to begin, if you've not already, seen evidence of our involvement in the state prevention agenda. It is making our communities healthier. Focus on chronic disease prevention, mental health, and substance abuse. Partnerships to encourage exercise, healthy eating, and lifestyle choices. This is all part of health. Programs and education to help navigate through that. And supporting Mike Hines, our county exec, in his Healthy Ulster initiative. We need to be right there with them. Part of this also is working closely with insurers. The traditional model is you line up at the table once a year and you negotiate the best rates you can, and then those rates are set for a year. Not so anymore. That's an ever-moving, constantly changing environment. So we've reached out. We do have a strategic partnership with our payer, CDPHP, at this point. We're driving preventive care and incentivizing wellness. And we're concentrating on ourselves. As the largest employer in Ulster County, it's our responsibility to be an example. And we are working, and have been the last year and a half, on a 3-year plan to provide a much healthier environment for our own employees And in doing that, we will develop a model that then will be and can be available to smaller businesses. As an example, we're partnering with Field Goods. This is something that has been generated recently, in which we have healthy foods delivered to employees who participate. Our goal is to be a healthy health alliance, and by that fact, an example to the community and a facilitator to ensure that the community becomes healthy. Now, integrated regional health system. No longer, and this has been a fact for years, but it's becoming even more clear, can anyone be a standalone? You must be integrated at some level with your partners. And in our case, it's our physicians, other hospital providers, county agencies, health plans, local businesses, integrate into the fabric of our community through our health influence. Now, the 1st of May, we went live with an electronic health record throughout all of our system. That is not an easy venture. We've experienced some slowdowns, as we know is typical of any sort of major conversion. Prior to this conversion, we had 3 different hospital systems. One at Benedictine, one at Kingston Hospital, and one at Margaretville Hospital. We rolled them all into a single system that has integrated the financial and the clinical portions. It's not an easy conversion. It has resulted in some service delays, particularly in our ED, and I apologize for that. We're working on it, and we're making progress. And this is something that, if anybody that has been through this in your own business, you know the difficulty and the challenges that come with it, and we're no different. We have multiple types of things involved in the complexity of healthcare. We have a team that is totally focused on that. So, what do we do going forward? Integrate and partner. As the largest employer, I know that our board and our team are totally committed to being a good community partner. We stand ready to answer any concerns, questions, but we know the economic impact that we have in this community and how important it is. We, 2 years ago was awarded the buy local emphasis. Now, the nature of healthcare sometimes prevents that, but we just under $8 million a year in local purchasing with local vendors. We want at any point in time to do as much of that as we possibly can. So, what is the future? What's our plan look like? It's not that complex. If you think about the services we currently provide, think of it in one building. It's not tremendously complex. I know there's a lot of question in the community about being behind the scenes and not sharing the plan. Well, there's some danger because there are no guarantees. And until such time as we are able to put together our funding plan to make it work, we don't want to go public with a plan that we cannot deliver. It's not fair to you, it's not fair to anyone. But I can assure you, if you know of services we currently provide, you can expect those services going forward, with very few exceptions. And the final plan will be determined by completing our funding package. So, What we do know going forward, fewer total inpatient beds because of the efforts that we talked about earlier. And this is an industry-wide effort. Going forward, we're paid on quality of care, not the amount of care. Most services, as I've said, will remain. Integration with our physicians and with our community is the top and must remain at the top of our list. And then obviously raising the capital to support it and allow us to get to that viable model. So, what's our mission? It's you. Help us know what that is. Understand that our commitment is to you in becoming the best that we can so that you can stay home for your care. There will be partnerships, etc., for care that we choose not to provide. Easier access to those that do, and that's part of the future of healthcare. Okay. Any questions?
We do have a few minutes left. Any questions from the audience? Yes.
Yes.
Which services won't be?
At this point, we've included all of them, but we don't, until we get that final plan, we don't yet know what that actually looks like. And that is dependent on, we want to keep everything. Now, it may change. We may see some services that have, because of volume, etc., we've looked at the volumes and we may reduce the size of the facility supporting it. But our intent is to provide, we're looking at all of our services. And as I said earlier, all of our services generate what's called a direct margin, which means it covers its direct costs. And so, keeping that in mind, we're going to keep everything we possibly can, but until we get that funding package in place and we can translate that to the physical plan, our intent is to keep the services that we currently have.
I have another question.
Sure.
When will Benedictine Hospital be the only hospital in the Kingston area? And are you going to increase the emergency room services that you currently have at Kingston Hospital at, well, obviously it'll be at Benedictine. Will there be more beds?
Actually, I'm glad you asked that, because as the decisions were made to distribute the services, and the ED was combined and consolidated at the, at that time, Kingston facility, we refer to it now as the Broadway campus. The core that you see coming in the door is what you would call state-of-the-art. No question about that. However, we were restricted in the amount of space and distance we could go out and build new. So we had to retrofit some of the current facilities. And for those of you who've been there, if you've gone to Fast Track, it's not so fast getting there because you have to go into a different section of the building. So our current ED, with the current number of beds, is not as efficient as it could be. We've tracked it. A nurse on any given shift could walk as far as 9 miles. Now that's excessive. But we retrofitted our Fast Track and the behavioral part of our emergency services. So, to get back to your question, the new ED will have it all in one area. So the number of beds will be similar, but it'll be far more efficient. And we can support it much better that way.
Okay, any questions? Holly?
David, are you involved in a discussion of what's going to happen to the Kingston campus once this transition takes place?
Well, the last thing in the world anybody wants is an empty building. No question about that. There are interested parties that have expressed serious interest. in repurposing the building. We've had some preliminary discussions. Obviously, those discussions will accelerate dramatically once we have a plan. But there is interest, and we feel encouraged. There's no guarantees, but we are encouraged that the facility will be repurposed. And our intent would be, as we move out into the Marys Avenue campus, that the new entities would move in. But again, a lot of moving parts, no guarantees, but we are encouraged by some of the discussions in that area. Okay.
Okay, anyone else? Yes, Kevin?
David, how many beds will you have in the new Marys Avenue site? And will any of the Marys Avenue site be, or will the total package be used? Will the whole site be used, or will parts of it not be used?
The necessity will be to use every possible amount of space at the Marys Avenue campus. The proposed plan includes a new ED, a new ICU with some additional med-surg beds, but our target would be around a little over 200 beds. Now, when you look at our census, we've been operating at about 70% occupancy. And so those beds on any given day haven't been used anyway. And when you look at the cost of supporting that and not having the volume, and as you look going forward, if we are successful in going forward, you will see less. Now, the only thing that will offset that is gaining market share. So, but if you look at same store today, you'll see fewer admissions. But in this community, we have some market share to grow, and so that may offset some of that. But the issue is we're going to use every possible space that's available in Benedictine with the previous Benedictine, Marys Avenue campus. But we get fined anytime the idea is it will be fully utilized. And if you think about it, offering the current services we provide with some modifications, you can begin to see why we could become viable, because we're not stretched. I have people going between campuses on a regular basis, and that's inefficient time.
Okay. Dan?
Dan, any chance of an alliance with a teaching hospital so that you can increase market share?
Well, our discussions have included a variety of what we would refer to as tertiary care systems. We knew when I first got here that we talked about this early on. We knew that the Health Alliance coming together was just the first step, not the last step, in preparing us as an organization to be a good partner. So we've been engaged in discussions with larger centers north, south. We have guests today from HealthQuest, Rob Dyson, the chair, and Greg Rakow, the vice chair, Denise George, the interim CEO. I mean, we have, I think, tremendous opportunities going forward. We're keeping the doors open with the commitment to be sure this community and surrounding communities gets the best care. So yes, we are looking at all of those opportunities. And we don't yet know where that's going, but what we do know is we've got good neighbors that have a similar type of desire.
Okay, James?
When do you expect the new financial plan to be in place?
I wish I could tell you. That is one of the more, well, okay. The state of New York is unique in its ability to make things take longer. We stand ready. We have worked with the Department of Health and others over the last year and a half, arm in arm. The Department of Health has endorsed our plan. They feel it is advocated for this community. They've echoed the fact that this community needs this hospital. And so we've received their support, but there's no single shot financial solution. And that's the challenge we have, is to work with the public and the private funding sources in putting that plan together. And we're doing that daily. And so we're hopeful that we can get that done soon, but I can't give you a date.
Okay, one more.
With the anticipated decrease in beds, what are you projecting for staffing decrease because of the less need, not only for nurses, but for maintenance and all others?
We have over the last, as I said, over the last year and a half in particular, looked at ways to further consolidate. We've reduced a significant number of positions, by far the majority of that through attrition. And there will continue as we go forward to consolidate services. We're looking at a 2-year time frame, at least, going forward. We'd like to think we could accelerate that, and we're doing what we can to do that. But to be on the conservative side, it's at least 2 years away. So what can we do in the interim to continue to consolidate, continue to make things better from a quality perspective, but also more efficient? So we look at opportunities for that, and then through attrition is our preferred method. But as we go forward, there may be some, but it will be minimal. That has to be at the top of our list, has been. When the Alliance came together, as I told you, the downside was 700 jobs lost, possibly. There were no jobs lost when the Alliance came together. Things have changed, so we're going to change with it to be sure that you get the care you need.
Great, thank you very much. David Lundquist, thank you. Thank you all. Have a wonderful summer. We'll see you back here in September. Thanks very much. Francis P., what happened?
Yeah, I know. I figured it was a good opportunity. Good. Yeah, nice. Hi. Oh, we are. How are you?
Good to see you. How you been?
Okay.
Great.
Introduce you to dinner. I'm editing the Shawangunk Journal these days, and I want to introduce you to Erin Donnelly, who I'm gonna give her to the queen of advertising.
Oh, great.
To help her.
Good. Nice to meet you.
Nice to meet you as well.
Good
Lord's
luck.
the king of Ulster County.
Yeah, not true. Thanks for coming. Paul,
Hey,
good
Wood.
to see you, buddy.
How's it going?
How's things?
All right.
Good.
Sorry to be a pain there running around
No,
with it,
no,
having
no.
to do these things.
Yeah. I actually thought you were in a live show.
Huh? Yeah. I probably should have done that, but I didn't think of it.
Well.
But we did do. I got video.